cerebral palsy, and in general some question and answers we took. In this session, sir is going to talk about optical illusions in CP. So sir has used his creative side again to name the topic, and we shall see what are the optical illusions that we see in day-to-day practice. So sir, over to you.
Good. So by now, I think people who are dealing with cerebral palsy, whether it's surgeons or therapists or parents, all of us feel that it's a big illusion. Right? And of course, we work hard, but there are a lot of illusions we face in the whole journey. And if anyone wants to just raise hand and unmute and just talk for a minute on what are illusions in cerebral palsy, I want to give a chance to anybody in the audience. And Neha, you want to say something? What are illusions? You want to unmute? Neha Rai, right?
Yes, sir. Yes, sir. Hello,
clear
sir.
Or
good
it's
evening.
illusion?
No, sir.
Yeah,
It's
hi.
clear. You can hear me, sir?
It's clear. I can hear you,
Yes,
but
yes.
just want.
Okay, sir. So,
So just
I guess you have already given in the WhatsApp group some illusions, like the toe walking,
yeah.
whether it's the TA or the knee or the what you say, jump knee gait. It's the rectus or it's the hams, right, sir?
Yes. So we'll see some more illusion. I'm going to go again at slow pace and talk little, and we'll have more questions. So there are many illusions in life. So here, you see the shadow and you have illusion of love, but actual reality is something else. And again here, the illusion is of a tree and the roots. And then you see a couple, the next stage, of having relationships. And finally, this is also an illusion. And then you can see this artist masterpiece that whether there is, which is the gate, one doesn't know, moving out of the relationship. So there are many illusions, and we continue from where we left last time. So we covered few points, and what I want to say that in cerebral palsy, there is interdependence between ankle, knee, and hip. There is more to it, and this interdependence goes to an extent that not only they are dependent on each other for movements, but they also create illusions. So that's what is seen in cerebral palsy. And I just want to give some examples here. A very simple example is that this is a child walking on toes. Some of you may have seen this in my possibly earlier presentation. So this is a child who is walking with pure equinus, knee straight. And this is a child where everything is synchronous. There is no illusion. Child is walking on toes. There is calf spasticity or shortening, and knee straight. So this is pure equinus gait. And if you treat the calf either with therapy or with splints, or if it's spastic, inject Botox, or if it's short, then lengthen the muscle, then you're going to be able to treat this child. So no confusions here. But if you see this child, suddenly the illusions appear. This child appears to walk on toes. But if you look at the ankle is neutral. So ankle is not responsible for his toe walking. What is responsible? If you look at the knee is flexed. So if any knee which is flexed beyond 30 degrees in stance phase will cause the heels to lift up and create an illusion of toe walking. Okay, so this is something important. That's why 30-degree flexion of the knee in stance phase is important, because if the flexion of knee is less than 30 degrees, it cannot give illusion of an activity at the ankle. So what happens is if the hamstring is spastic or hamstring is tight, or if there is a pelvic problem which stretches the hamstring up and causes the hamstring to bend, or if the quadriceps are weak, any of these can give rise to knee to bend. Many times if soleus is weak, the tibia cannot roll over behind, and that also can cause the knee to bend. So whatever is the cause of knee being flexed, what happens is knee flexion more than 30 degrees will give rise to heel to lift off. So whenever you have uh, the first phase of stance, which is the initial contact, uh, at that stage the heel is supposed to touch the ground, but instead of heel touching the ground, the toes will touch the ground.
Right.
And we feel that calf is tight, and many of these patients are treated by looking aggressively at calf. There is no fault of calf, but we stretch calf muscles. Some of us will splint calf muscles, some of us will plaster calf, some of us will inject botox in calf or even lengthen for no fault of calf. And here a child who was walking child become non-walking child. Now we see a third illustration here where child is walking plantigrade, is walking on the foot. But if you look at the ankle is in equinus. But this equinus is not apparent, it is hidden. It is There is an illusion that equinus is not present, and this is because the knee is in recurvatum. So there are few
Right.
points we understand here is that how ankle behaves depends on the knee. If knee is straight, the ankle behaves as the ankle is supposed to be. However, if knee is flexed more than 30 degrees, then ankle will behave as if it is in equinus, though it is not in equinus. We call this as apparent equinus. If the knee is in recurvatum, the ankle will behave as if it is plantigrade, though it is in equinus. So in first stage, we have to treat the calf. In the second stage, we have to treat the hamstrings or the knee. And in third stage, where there is hidden equinus, actually we have to again treat the calf. The orthosis will be again different. In the first case, you're going to use an AFO, either static AFO or hinged AFO, depending on the selective motor control the child has over the ankle. In the second case, what you have to do is actually you have to use a solid AFO, maybe sometimes in plantar flexion, in order to cause plantar flexion knee extension couple, and you will concentrate more on the knee. Okay. And in third case, it's important that we don't use a solid AFO. In fact, we use a hinged AFO, which allows the tibia to roll forward. And sometimes you can use a knee brace to prevent the knee from going into recurvatum. When you do that, suddenly the equinus will manifest. So these are some of the optical illusion in a very simple case, a toe-walking child. So you can see this child. This child is walking on the toes, and you can. I just want somebody to tell me among the participants. I'm going to pick up. Aditi is there. Aditi Nima from Indore. You want to unmute yourself, and then yeah. What is your opinion about this? Aditi, are you there?
Hello. Good
Yeah,
afternoon, sir. Can you hear me? Yeah.
Hi.
Hi.
Yeah, I can. So what do you feel? This is a child you're seeing in your clinic. He's walking on toes, and the orthopedic surgeon has advised him to do calf lengthening procedure and maybe something for hamstring. What is your this is not complete evaluation, I agree, but just from this video, what are the things you want to you observe? I hope this is
Right.
seen clearly on.
Yeah. So you want to know what I feel here? So I think there. It looks
Yeah,
like
what
there
is
is.
your
Yeah. It looks like there is a hamstring. See, it is a crouch gait for sure, and there is hamstring tightness, and yeah, and the kid is toe walking, so it is calf
right?
calf maybe.
And
Yeah.
so, will you give A4 ankle foot orthosis to this child? Yes or no? What happens if you give A4 to this child?
Sir, yeah, we'll give AFO to this child, and he will, sir, without strength, knowing the strength, we don't know AFO, which kind of AFO, I'm not sure. As
Absolutely.
of now, yeah.
So one thing, you're absolutely right. Strength is an issue. That's why the child and start walking independently. One more observation what we make is that
So your audio
the
is
hip is
breaking.
actually being, okay, is it okay? Better?
Yeah, yeah.
Yeah. So if we see the hip of the child, the the hip is going behind the ankle. The whole entire weight bearing axis is behind the ankle. So what is happening in this child is on the right side, though there is child is walking on the toes, if you can see again, you know, the ankle is at 90 degrees. So this is apparent equinus on the right side. And the main problem is in hamstring here. The hamstring is so tight that it is pulling the pelvis posteriorly. Okay. Now, the same child, if on the right side, there is mild equinus. But this equinus entirely does not explain the toe walking. So, and this is a child where calf is not much at fault. Hamstrings are the culprit here. And in this child, a major sort of work should be on strength and on hamstring stretching. This child, after examination, we found out the hamstrings were spastic, not short. And we decided to give Botox in medial and lateral hamstring on bilateral and put him in some sort of plaster and his walking improved. Now this child, if you give only A4, what happens is he'll comes down, but he will tumble posteriorly. And the only way he would be able to walk would be with a posterior walker. So if you have to improve alignment and make him to walk with more energy efficiency, what he will require is a combination of taking care of his hamstring length and at the same time taking care of his foot stability by A4. Okay, so this is apparent
Solid air.
equine. Yeah, solid A4, absolutely, not hinge. So this is apparent equinus bilateral. Now I'm going to put one more video here, and I'll ask someone to comment. I think Dimuthu is there. Dimuthu from Sri Lanka. Right. He's an orthopedic surgeon. Dimuthu, can you unmute yourself? Yeah, I'm done it. Yeah. Dimuthu? Yeah. Yeah. So what is your impression about this child? He's walking almost on toes. And what is happening to the knee? Can you see this video? So there is excessive lumbar lordosis. We can see that pelvis is tilted forward. And what is also happening in this child is knee is in excessive recurvatum. And though he is in equinus, the knee recurvatum hides the equinus. In fact, equinus is a precursor to recurvatum. And this is a child, though he's a small child, 3 or 4-year-old child, it is essential to tackle calf in this patient because if you don't tackle calf, the recurvatum will become malignant. It will become irreversible. So this child, again, it was spastic calf, and what we had to do was just inject Botox. And we also did very, very minimal myofascial release to lengthen the calf, only gastrocnemius, so that his knee could be balanced. And it took almost 2 years for this knee recurvatum to subside. So again, when we are dealing with ankle, knee is important. Okay. So I'm going to give you some more examples here. This is example from a knee. This is a child who is walking with knees which are flexed. Okay. Now, when a child is walking with knee with flex, you also need to look at feet and the hips. So as we are looking at this child walking like this, what we realize is the weight bearing of the trunk axis is almost posteriorly. It is not going anteriorly. There are two type of crouches. Crouches where the trunk is aligned to the feet. Okay. So here we can see that trunk is aligned to the feet. If I draw a straight line, it goes in between the feet. So the trunk is aligned to the feet. So that's a type of crouch. One second, let me clear this. And if we do a gait analysis for this child, I've just put a gait analysis so that you can see what is actually happening. The ankle is not so bad. Okay, it goes in little bit of dorsiflexion, but otherwise pretty well good movement. Knee remains in flexion throughout. At the hip, what we see is that there is little bit of flexion, not much of a problem. But if you see the pelvis has marked posterior tilt. So these are the children who have too much of hamstring tightness. And here, the only way the knee can be straight, they can be walking upright, is by doing a very judicious lengthening of hamstring. You should not over lengthen hamstring. If you over lengthen hamstring, then he will lose his pelvic balance. So you have to be very judicious. And as a surgeon, I would do only medial hamstring. And whenever possible, conserve that hamstring either by doing only aponeurotic release, or if I'm doing an open release, then attach the semitendinosus back to the femur so that it can continue to act on the femur. Okay. So this is a
Sir, I had a question.
yeah, bolo na, yeah, please.
So I think there is a thoracolumbar break also there at the spine.
Absolutely.
And
So
that is
why
like,
do you think that is happening? You can see
so,
it very well here. Yeah.
yeah. So some sort of a compensation for the posterior tilt of the pelvis.
Absolutely. He's trying to bring his entire body in line with the center of movements, and that's why even his there is the entire pelvis being tilted forward gets spilled over to the thorax. That is what is happening.
Right.
So so here hamstrings are short. This child had no spasticity, fixed hamstring shortening, no knee flexion deformity, and the lengthening hamstring was a treatment in this child. Now, if you see this child, he's also walking on toes. He's also crouch gait. And if you see, he's walking actually with trunk bent forwards. There's a difference in the previous child and this child. Okay. And when we look at the gait study of this child, the ankle is in marked dorsiflexion. Knee, of course, is in massive flexion. Hip also is in quite a bit of flexion. And then pelvis is tilted anterior. So this is known as decompensated crouch. This is a patient in which the primary problem is in pelvis. The pelvis is tilted forward because of weakness. Sometimes these children may be having rectus tightness. Sometimes they may be having psoas tightness, which is to be examined with a clinical evaluation. Okay, but what is the major problem in this child? I want to say is hamstrings are not short because the pelvis is tilted forward. The origin of the hamstring over the ischial tuberosity gets raised up, and because it gets raised up, the only way he can walk is by flexing the knee. Because if he doesn't flex the knee, the pelvis will become unstable. The hamstring are giving the tension, like how when you play fly kite, there is someone who has to feed in the rope or manja. Similarly, hamstring have to feed in, otherwise the pelvis cannot be. So I would just request somebody who's having, I think I can find out some sound coming, from somebody. So so here the treatment is not lengthening hamstring. One should be very judicious. So I will stabilize the feet by giving AFO or doing a feet correction surgery. And the psoas were tight. So in this case, we had to do proximal lengthening of rectus and psoas to get pelvis at level so that the hamstring becomes proper length. And it's very, very important is the role, as Adli was saying, role of muscle strengthening in these cases. So, though both these children, what we saw, are walking with knees bent, there is tremendous amount of difference in why they are walking with knees bent, and the treatment is completely different. First was the patient who was GMFCS 1 or 2 and had good muscle strength, okay, where length was a problem. Second is a patient where length is not a problem, but strength is a problem. And both have to be treated in a completely different way. So there is no standard formula for crouch. And as a therapist or orthopedic surgeon or orthotician, we'll have to learn to differentiate between these conditions. because if we treat both with Botox, if we treat both with surgery, or if we treat both with only strengthening exercises, we are not going to get good results. Our approach has to be different. Okay, so again, I will illustrate this with retroverted pelvis. This was, and in second case is when the pelvis is antiverted. When pelvis gets antiverted, the only way the child can walk is with knee bent, and we need to differentiate between. Okay, so some lighter movements again. This is an incident where there is a person on an island, and he's alone, and he suddenly sees a boat, and he has some hope. On the other hand, if you look at the person on the boat, he's been in the sea for last 15 days. He has not seen the land, and he suddenly sees this land, and he has a hope. So your hope depends on whether you are on land or on the boat. And this is also an optical illusion. It's illusion of mind. And we know that whichever situation they go to, the person on boat goes to the land, there is no hope. The person on boat goes on the land, again it's a similar situation. So it's important to realize that we should not, in CP, go from one trouble situation to another trouble situation. A child who's walking with crouch, someone does unjudicious hamstring lengthening, and he becomes dependent on walker, dependent on KFO. It's not a good situation. So we always want to go from a not so good situation to a good situation, and that can be done only when we learn to see things properly. So one of the ways is to use a camera. You can use a mobile phone and take a video. And what I would like to suggest is people who are in the audience, at least take one video of a child with cerebral palsy. Or if you have an older video, I don't know, because no one is practicing now, it's difficult to find a video, but you can request your parents. And if you have an old video, take a video and write down description. How is the child walking as seen on the video? What are the points you have learned, and what is the management depending on those points? And what we'll do is next Friday when we start, we can start with 3 best videos which are sent by people who are watching this program. So pick up any child, who's a walking child with CP, take a video. You don't need a 3D gait analysis always. If you have access to it, it is good. There are some cases who definitely need it, but first step is to learn to do a good observational gait analysis. And what I want to do is go through details of observational gait analysis with mobile phones, which everyone has. And the way to start will be with videos which are sent by the audience. So you can send the videos to Sankit. We can share your number on the WhatsApp group,
Yes.
and people can send to you, and you can select 3 best videos which are going to. Those who have not seen a gait lab, it is just a small ground. It's a big hall with 8 cameras. There are markers which we put on the patient's body. There are force slit for us to measure the ground reaction force, and for us to give kinetics. And some of the gait labs also have EMG and pedobarograph. We don't have that at Jupiter Gate Lab, but we have cameras, we have markers, and the force plate. So how walking is seen in gait analysis versus normal walking. So on top you see a video of a child who's been shot with a normal video camera. Are you able to see this? Okay. Sanket, are
Yes.
these videos visible? Okay.
Yes.
So this is a child
Yes.
walking, and this is how a gait lab sees. So what we see are multiple markers, and the computer makes images with these markers. And what you see here are these blue lines are the ground reaction force. And this can be this also then gives rise to these graphs. There are total 12 graphs. There are graph for pelvis, hip, knee, and ankle. And each of these graph is in a lateral profile. As we see a lateral view, they are from frontal profile, which will talk to us about varus, valgus, adduction, abduction. And then they are in a transverse profile, which talks to us about internal and external rotation at each level. And these graphs are studied then, and then we compare it with the child's clinical examination. We compare it with observational gait analysis. We compare it with X-rays and CT scan, and then give you all a report. So this is a child which qualifies for a crouch gait. So I just wanted to say that every child who walks with knee flexed is not crouch. If a child is walking with knees bent, but if the ankle is in equinus, we will call it as jump gait. If the child is walking with knee bent, but if the ankle is plantigrade, then we call it as apparent equinus. We call a gait as a crouch gait only when a child walks with knees bent, ankle in dorsiflexion, and hip inflection. It has to fulfill all the three criteria. If we look at the gait analysis, if the knee flexion in stance is more than 30 degrees, then only child qualifies for a crouch gait. If the knee flexion is 20, with ankle being in neutral or little dorsiflexion, it is not a crouch gait. So every child who walks with knees bent is not crouch gait. The difference between crouch and a jump gait or apparent equinus is that crouch is a gait where you have lost the energy center. The ground reaction force is behind the knee, so much behind the knee that the body weight causes the knee to go into more and more and more flexion. And the only way a child can resist this is by contracting his quadriceps. Normally, we don't require quadriceps to walk. Very hardly any movement we require. But child with crouch gait requires tremendous amount of strength in quadriceps. And because of this, the patella goes up because of persistent pull of the quadriceps, and we get patella alta. Now, if you see this child walking from the gait analysis, there are a few things which I want to discuss is that, of course, we know that the knee is in flexion. So you can see here that knee is in flexion. काय झालं? पेन नहीं आता. So knee is in flexion, we know. We know that hip is also in flexion, and pelvis is posteriorly tilted, which means hamstrings are tight. Ankles are in dorsiflexion. Okay. Now see the fun of optical illusion here. This is the child. Anyone would say that ankle is in dorsiflexion, so calf are overstretched. That is, soleus is dysfunctional, gastrocnemius is dysfunctional. He requires AFO. Without an ankle foot orthosis, this cannot be managed. Okay. Somebody would say that hip is in flexion, so you need to release psoas, lengthen the psoas, or inject Botox there. Now, this child was treated only with isolated hamstring lengthening. Medial hamstring, we did an isolated lengthening. And after this, I just want to share what really happens is that when you have knee in flexion, if you see the distance of hamstring from the center of rotation of the knee, the distance is large. So there is good lever arm, beneficial lever arm at the knee whenever the knee is bent. And hence hamstring, which is a biarticular muscle, because it finds it advantageous to work at the knee, it will keep on bending the knee more and more and more. Okay, Sanket? At the same time, because hamstring, lever arm at the hip shortens. So hamstring finds it not so beneficial, not profitable to work at the hip. And that's why hamstring does not act as a hip extensor. That's why the hip goes in flexion and knee goes in flexion. Now, same thing applies to gastrocnemius. Gastrocnemius is also biarticular muscle. It is mirror image of hamstring. Hamstring runs from upper end of tibia to pelvis. Gastrocnemius runs from lower end of femur to the calcaneum. Right? It is mirror image of hamstring. So whenever knee is flexed, the origin of the gastrocnemius goes further apart from center of rotation of the knee. So lever arm for gastrocnemius for the knee joint increases. So gastrocnemius finds it more beneficial to work on the knee and causes further knee flexion. At the same time, gastrocnemius finds it more unprofitable to work at the ankle. And because gastrocnemius does not give rise to push of power, the ankle goes in dorsiflexion. All the time we talk about effect of ankle at the knee, that ankle dorsiflexion, overstretching of calf, lengthening of calf gives rise to crouch. But no one speaks about action of knee on the ankle. Okay, so this we are going little deep into biomechanics, where we are. I'm telling you that if the knee is in flexion, the ankle will go into dorsiflexion. It is not necessary that because ankle is in dorsiflexion, the knee is going in flexion. Knee flexion also can cause the ankle to go into dorsiflexion. And unless you correct the knee flexion, the ankle dorsiflexion will not correct. So here in this case, if you can see,
Sir, your voice is breaking.
okay. Is this clearer now? Better? Tell me. Yeah.
Yeah.
Just wait till it becomes clear. So what I will repeat what I said is that biomechanically, when the knee is straight, gastrocnemius and the hamstring prefer to act on the hip and ankle. The hamstring prefers to work as a hip extensor. The gastrocnemius prefers to work as an ankle plantar flexor. When the knee is in flexion, the hamstring prefers to work as a prefers to work as a knee flexor, and hence its action on the hip extensor becomes weak, and that's why hip goes into flexion. Gastrocnemius, when the knee is flexed, prefers to work as a knee flexor than ankle plantar flexor, and hence it produces more knee flexion and allows the ankle to go actually into dorsiflexion. So hence, it is important to correct the knee flexion attitude, because when knee flexion attitude is corrected, when you give Botox in hams and calf, or when you lengthen hamstring, when you do PMFR of gastrocnemius and medial hamstring, what actually happens is you are straightening the knee. And when you straighten the knee, the hamstring comes closer to the knee, and hence the lever arm of hamstring and the knee becomes disadvantageous. Hamstring doesn't want to work any longer as a knee flexor. The hamstring wants to work as a hip extensor. When you correct the knee flexion deformity, similarly, the gastrocnemius now wants to work as an ankle plantar flexor. It does not find it profitable to work as a knee flexor. So whenever you correct the knee flexion deformity, you will find that the power of ankle plantar flexion will increase and power of hip extension will also increase. This was the point I was going to make. So if this point is clear, then we go ahead. If this point is not clear, just unmute and ask a question. Or you can raise your hands. So we get this facility on Zoom, and raise your hand. Okay, so yeah, so Persis is asking, can you explain this again? Yeah, I'll explain this again.
Yeah,
So what
sir,
I am,
and
okay,
even I had this thing like when soleus is weak, the extension moment at the knee also weakens.
right,
They say soleus contributes 50% of the extension moment
absolutely.
at the
So
knee. In lengthening, like you mentioned, lengthening right now, hamstrings and TA. So how do you do the lengthening?
soleus, the advantage is soleus is divorced from knee. Soleus is attached only to tibia. It does not get attached to the knee joint.
Right.
So position of the knee does not affect soleus, but position of soleus will affect the knee joint. Position of soleus will affect the knee joint, because if soleus has good strength, with the ankle being locked, it pulls the tibia behind. In the stance phase, it does not allow the tibia to roll forward and prevents knee flexion. So soleus by itself is a completely different ball game. Similarly, adductor magnus is a different ball game, because adductor does not cross the knee joint. Okay, the hamstring part of adductor magnus is mainly for stabilizing the hip. It does not cross the knee joint. I'm talking about two muscles which cross the knee joint and one more joint. Hamstring is a muscle which crosses knee and hip. So position of the knee determines the hamstring action. When the knee is straight, the hamstring is mainly extensor of the hip. When knee is flexed, the hamstrings act as a flexor of the knee. Okay, similarly gastrocnemius, when the knee is straight, the gastrocnemius acts as plantar flexor of the ankle. But when the knee is bent, the gastrocnemius acts as a flexor of the knee joint. And all this is happening because when the knee is bent, there is a favorable lever arm for hamstring and the gastrocnemius to act at the knee joint. Okay, I hope this is clear now. So if it's not clear, what you can do is go and watch this video again on YouTube and the link. And then those who are still having doubt can send me a WhatsApp message. I will explain that again. But we need to move on. Okay. So okay, we move on to the next slide. Okay. So it's 5:36, and
Yes,
I
it's
think
5:30.
yeah. So I think we will end the lecture here. There are two more patterns which I want to discuss biomechanically. So I think it has been enough of a dose. In when we do surgery or Botox, we talk of the right dose. So we also should talk about the right dose when we are talking and explaining. So what we have learned today, I will summarize. We spoke about optical illusion in cerebral palsy, and then we saw the effect of knee at the ankle. Okay, so anyone wants to summarize effect of knee at the ankle from the audience? Yeah, just unmute yourself and you can come alive. Who wants to do this? Can I ask Nidhi? Nidhi from Pune. You want to try? So unmuting Nidhi. Yeah. Yeah. Let's try about action of how does position of knee affect the ankle? Just tell us in short. No, we can't hear you. Yeah. Can you hear? संकेत आवाज येतोय का तुला?
Nine.
नाही ना. Anyone else wants to try?
So can I
There is
try,
a
sir?
button if you see.
So can I try?
Yeah, please.
Yeah,
Yeah,
Nihal.
please.
Neha.
Yeah, please. Yeah. Yeah.
So what I understand, sir, is that if knee is straight, then hamstring will act as a hip extensor. But if knee is in flexion, then hamstring will act as a knee flexor.
Okay.
Right, sir?
Yeah. So if the knee is extended, the hamstring will act as a hip extensor.
Extensor. And if
the
it
knee
is flexed,
then hamstring will act as a knee flexor. I understand.
knee flexor.
Yeah.
Then
So I'm
coming to
talking about-
gastroc,
Yeah. Tell me.
when the knee is straight again, it will act as ankle plantar flexor.
Okay.
And
When
when the
it's
knee
flexed. Yeah.
and when the knee is flexed, it will act as a knee flexor.
Absolutely. Right.
Right, sir?
Right. So now I want you to continue and tell us, when we started, we spoke about effect of knee at the ankle. So if knee is straight, knee is flexed, or knee is in recurvatum, how does it affect the ankle? Can you summarize that part?
Yes, sir. So then if the knee is straight, ankle should be neutral.
Okay.
If knee is flexed, ankle would be in plantar flexion.
Okay.
Or it would be, if knee is flexed more than 30 degrees, it would be ankle dorsiflexion, which would be crouch.
Okay.
This is what I understood, sir.
So now I will clarify this. What I want to say, when we look at the ankle, what is happening to the ankle depends on the knee. Okay. So if knee is straight, the ankle will manifest as itself, as it is, without any change. Okay. If the knee is flexed, the ankle, the patient will walk on the toes even if there is no equinus. Right. Okay. So a patient with ankle actually in dorsiflexion and knee flexion, you can be walking with heel raised off the ground, even though the ankle is neutral or in dorsiflexion. So this is known as apparent equinus if his ankle is plantigrade. But if ankle is dorsiflex, then we call it as crouch. Yes. The third condition we saw was if the knee is in recurvatum, even if the ankle is in equinus, so whenever you look at the plantigrade,
So your voice
but
is breaking.
knee is straight. If the ankle is plantigrade, but if the knee is straight, then it is a normal walking. If ankle is plantigrade but knee is in recurvatum, so the child is walking with the foot flat, but if the knee is in recurvatum, the ankle can be actually in equinus, which we call it as hidden equinus. This is one situation. The second is heels off the ground. So when child is walking on the toes, if the knee is straight, that is a true equinus. With child walking on the toes, if knee is flexed, then it can be apparent equinus. Okay, so that's what we understand. Okay, Sanket, I want you to talk about how condition of knee and pelvis, they are interdependent.
Right. So pelvis, there are two. The way I say it is either the pelvis is posterior or it's anterior. So when the pelvis is posterior, usually with tight hamstrings, the center of gravity goes behind, and then you see compensatory mechanisms to get it within the base of support. Ultimately, we have to get the COG within the base of support. So that is one, and then the other is when the pelvis. Can you hear me?
Yeah, I
Hello?
can hear you
Yeah,
very
yeah.
well. Yeah, we can hear you well.
Okay. And the other thing I understood is, when the pelvis is anteriorly tilted, so that is usually because of short hams, which are not necessarily tight, but it's because of spastic hip flexors.
So if the pelvis is tilted forward, even if
And
hamstrings are not tight, you will feel as if the patient is walking with knees flexed. So one has to
right,
differentiate between two gaits, because in first
differentiate
condition
between
you will
the two.
lengthen
Correct.
hamstring. In the second one, you will actually stretch the hip flexors and strengthen the hip extensor. You will work on the strength and not so much on the length. So one is issue with the strength and one is issue with the length. I just want to show you what happened to this child where we treated him. Yeah. So this is the child with that crouch. You can see this. Can you all see? Yeah, you can see now. This was the child which we saw, who had ankle in dorsiflexion and the hips were in flexion, right? Now all we have done is judicious hamstring lengthening for the child. So now you can see the knees have become straight for the child. Of course, he has undergone therapy for quadriceps strengthening, hip extensor strengthening, etc. But if you can see that this ankle, the lower graph, ankle which were dorsiflex have become normal angle without doing anything to the ankle. Okay. If you see the hips, if you look at the hips, these hips which were flexed have completely come into line without doing anything to the hip flexors. So as a therapist, you should play around with the joint angles and look at interdependence. And I'm sure you will find a lot of examples of this in day-to-day practice. The God has created biarticular muscles for the same reason. If God wanted to make it simple, he would have created one muscle for every joint. Why we have hamstrings which are hip extensors and knee flexors? Why we have adductors which is hip flexor and knee extensor? Why we have gastrocnemius which is knee flexor and ankle plantar flexion, plantar flexor? God has created this chain for shock absorption and power transmission. So we must respect these chains and understand them, so that our therapy or gait training and interventions can become better. Okay, so this was a little difficult topic I